Hello, am I audible, ma'am? Okay, okay.
Hi, Shreyasi, I can hear you well.
Yes, ma'am. We will start at sharp 8 o'clock, right?
Yeah, Shreyasi, I was
Yes.
speaking to Pratima Anand.
Okay.
Is it possible to transfer all the participants to this platform? I would like to interact with them rather than make it a didactic lecture.
Okay. You need to speak with Sangeeta regarding this, ma'am. She can help you.
I think maybe Pratima will speak to her, so you can't do
Yes,
it.
yes.
You
No,
can't
no,
do
no.
it as a host.
No, ma'am.
Hmm. And Sangeeta is available now to do the need.
Yes, yes.
Can you talk to her?
Yes, ma'am. Just give me a minute.
Hmm. And also, please enable screen sharing for me.
Yeah, sure. You can share now, ma'am, for the checking purpose.
No, it says host disabled participant screen sharing.
Okay, just a minute. Now, check once again, ma'am.
Yeah, I can do that now.
Okay.
Shreyasi, you can let me know when I should start. Okay, Dr. Tapas has joined. Hi, Dr. Tapas.
Ma'am, Sangeeta is doing the needful, ma'am.
Hello,
Okay.
Shreyasi?
Yes, ma'am.
Yeah, can you make me co-host? I can actually shift the
Yeah,
participant.
yeah, yeah. Sure, sure, sure. I'm just. Yes, you are now closed, ma'am.
Good evening, ma'am.
Good evening, Tapas. New shine is a big responsibility for you all, I'm sure.
Yes, ma'am. We're trying to do it, ma'am. Actually, it's very difficult to engage the students, ma'am.
Yeah. And that is why I also thought it would be good if they have joined, let them be, someone where I can interact with them rather than
Yeah,
didactic.
yeah.
Fatima, are there any whom you have to transfer?
Yeah, ma'am. Yeah, ma'am. Actually, 12 have joined,
Right.
so I'm sharing the faculty link with the others.
Okay, sure.
Yeah.
This is 8 to 9, right? Tapas,
Yes, ma'am. Yes, ma'am.
yeah,
Yes, ma'am.
1 hour. Fine.
I think, ma'am, students will be joining. We'll wait for 3-4 minutes more.
Should
We
I?
have
Okay.
the message. Yeah, they are
Then
joining.
maybe I will just start talking to them and maybe 3-4 minutes I can start the
Yes, yes, yes,
presentation.
yes, yes. We can just
Yeah,
build the background
yeah.
and all. So, yeah.
Um, so good evening, everyone. I see a few of you all have joined already. Um, I am Dr. Suman. I work as a neonatologist in St. John's Medical College in Bangalore. Um, it would be good if I can, know who are my audience today. So may I request you all to just maybe type in your name and also from which institute you all are. I guess that all of you all are postgraduates of different years. So if you could just type it in, it would help me to, just encourage me a little more. So request so many of you all, Akash, Danuja, Ashwini, Sinduri, Gautam, Krishna, Kamalavadi, Jikita, Can you please type in your name and which institute you all are from? And as we wait for others to join, I am just looking at the chat to know from where you all are. No one? No one yet? I'm sure postgraduates are very good with messaging, typing. So I thought by now, all of you all, if you all are here, would have. Thanks, Akash. You're setting the ball rolling. I see that you're from Father Muller. Okay, the others also, please. Don't worry, I'm not going to pull you up and ask you all questions. Andhra Medical College. Okay, Simran. Welcome. So either Pratima or Shreyasi, let me know when I can start. Okay. So we have Sinduri from Government Medical College, Ongole, Andhra.
Pratima ma'am, shall we start?
Yeah, yes, ma'am. I think we can start. People are
Okay.
joining. Yes.
Yeah.
So after the introduction, I will hand over the session to Dr. Shuman, right?
Okay, I can introduce myself if you wish.
Yeah, yeah,
Not
sure.
a problem.
Should I hand over the session to you, ma'am, or Dr. Pratima?
Yeah, Dr. Suman can take over, Shreyasi.
Okay, okay, yeah,
Yeah.
Yeah.
okay, okay, sure.
Go ahead, Shreyasi.
Yes, start. So, good evening and a warm welcome to all the dignitaries present here. I'm Sreshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It's with great pride that Planet serves as the digital partner for this event hosted by the National Neurology Forum, and the focus of today's session is NNF Shine Week to South Zone. So let's begin today's session, for which I would like to invite Dr. Suman Rao ma'am to take over. Over to you, ma'am. Kindly proceed.
Thanks, Shreyasi. So as you heard, I think similar sessions are happening in all the zones. And therefore, I think there were a lot of little background noise, but that's okay. So good evening, everyone. I see around 49 participants are here. And today's session is on breastfeeding. And I am Suman Rao. I'm a neonatologist who works in St. John's Medical College, Bangalore. I also work as a consultant with the World Health Organization. And today what I'll be doing is using the slide deck, which National Neonatology Forum has prepared exclusively for NeoShine, which is based on the FBNC module. I'll be sticking to that, but I would really like us to have a good interaction, and therefore I have requested that all you participants come onto this forum where you can chat with me, you can raise your hands, and we can discuss challenges, because breastfeeding is something that we all think we know very well, but it is very, very challenging when you actually practice it. And one reason why I'm very happy to address you on this field is because as pediatricians, I think sometimes we are the biggest barriers to breastfeeding. We sometimes give advice which may not be the best. And therefore, we need to really build our own confidence in all mothers for breastfeeding. So let me start sharing my screen. And as I progress during this lecture, whatever doubts you have, small or big, relevant, irrelevant, I would like you to put it in the chat, and we'll come back to it at the end of the session. I want to actually stop on the dot at 9, which I'm sure will help you too. So let's start with this breastfeeding module. And if you have something pressing, I am okay. I can see the hands, the virtual hands. So if there's something you would like to be addressed then and there, I'm open to interrupting the lecture and taking on your questions. So I hope that I can make myself clear. So let's start off. So maybe just to get it rolling, I would like all of you all to just raise your virtual hands so that, we are interacting. And you continue to put your names and your colleges into the chat. So maybe at least a show of 4-5 hands. Something coming up? Because I know how virtual platforms are. Sometimes they're on their own. So let me see a few hands up, few of your virtual hands, not your actual hands. Okay, not a single one. Postgraduates are supposed to be very good with their fingers. Mhm.
I think 4 or 5 people have, yeah.
Okay, great. Okay, so I can see that. So let's now start off this, okay? So if at all there are some things which is very, very specific for pediatrics, it is growth and development and breastfeeding, and of course, immunization. So today we'll be taking a very important topic on breastfeeding. And this topic, I find it particularly important because the whatever, even if you talk more about it, it's still less. Probably this is the most overarching part of newborn and infant care. If we do it well, then our jobs as a pediatrician will be much reduced because the illnesses are reduced and babies are doing well. So we all know this, that breast milk is the best nutrition for not only the newborn baby, but throughout infancy. And it contributes a big thing for the nutrition of the toddler in the second year. So it's not only for the newborn, it's very important for the infant. It's a wholesome nutrition for the first 6 months. But please remember that even beyond 6 months, even beyond 1 year, it is a very important source of nutrition. And if you look at the interventions which can affect under 5 deaths in the newborn series from Lancet, exclusive breastfeeding is right on top. It can prevent 13% of the under 5 deaths. Everything else, whether it's your vaccination, whether it is, treating malaria, whether it's anything else, is much, much lower. So the single most important thing which can reduce under 5 deaths, which can improve newborn mortality, which can improve child survival is exclusive breastfeeding. And in that, as we say, well begun is half done. Initiation of breastfeeding within the first hour is absolutely important. In fact, doing it well, if you do it for all babies, it can save 1 million lives per year. And in India, thankfully, both traditionally and with the government importance, breastfeeding is a very, very important intervention that the government of India has recognized. And currently, we have the MA program, very aptly named. That's the MA program, Mother's Absolute Affection Program, which looks at how breastfeeding is not a medical intervention, but a social intervention. And therefore, we need to have an enabling environment to promote and support breastfeeding at all levels of care. And that's something that we'll be discussing more. Now, as I said, breastfeeding is so important, but at the same time, when you see the numbers, it's quite shocking. While we say that all babies should get breast milk within the first 1 hour of birth, more than half of them don't. As per the NFHS survey, and I don't think it has changed much over the past few years, only around 41% are actually breastfed within 1 hour of birth. And a big chunk of babies who miss out on this are the sick babies, are the small babies who go into the NICU. Now, even for them, it is absolutely important that we get the milk, first milk or the colostrum into them within the first 1 hour. And it's important for us as pediatricians to recognize that. The other very important thing is that exclusive breastfeeding is still reaching only half of the population. At 6 months, exclusive breastfeeding is only around 54%. In my own unit, we have a paper, I think in 2014, that we came out with, which showed that in a baby-friendly hospital like St. John's, where many of us are not only promoting breastfeeding, but we are quite fanatic about it, we found that exclusive breastfeeding rates at 6 months was only 16%. And one of the main reasons for it was, and this was not by recall, when you take it by recall, when you ask families, are you exclusively breastfeeding? Most of the time you get a response like this, around 50% say yes, they are exclusively breastfeeding. The study we did was by an isotope study where we actually checked whether the baby was getting something else by deuterium oxide. And we found that a lot of babies were getting water. And a simple messaging now that we do is don't give anything else to the baby, not even water, because many of them do give water. So there are a lot of challenges which we need to address. So what are we going to learn today? We're looking at advantages of breastfeeding. We are looking at how to help the mothers with the correct technique, how to enhance lactation, what are the difficulties and how do we address them, and also about expression of breast milk. So advantages of breast milk. Now, this has been, what we have talked about. Okay, I would request, these are going to be the challenges of having everyone on board. I request Shreyasi, unless they lift their hand and they want to talk, to mute everyone else. So the advantages of breastfeeding, as we know, are to the baby, to the mother, and to the family and society. For the baby, it is the complete food. The complete food, not only for the growth of the baby, but very importantly here, that is for the development of the baby. One important factor which has not changed over the past 50 years since we have been researching and promoting breastfeeding since BFHI is that it is a big, big protector against infection. And this you don't get with any formula. And that's why we say that the first feed is the first immunization of the baby. It's of course very easily available. It is easily digested and it has benefits much beyond the infancy, much beyond the childhood period. Even as adults, it exclusively breastfed babies who have been breastfeeding are protected to a large extent from allergic problems like eczema, asthma. Staying in Bangalore, I know how big a problem asthma is. And very importantly, it provides a very strong social development for the baby. Not only emotional bonding with the mother, but also it makes them much better citizens. Anger issues, how they deal with, problems, stress, all that is so much better when they have been babies and they have breastfed. Of course, breastfed babies have higher IQ. We have no doubt. I always recall one of my teachers who say, if you give cow's milk, your baby is going to get a cow's brain. Do you want that? And maybe the ranks in your NEET exams may be decided by whether you were exclusively breastfed or not. Doesn't mean that you have to go blame your parents for it. But the point I'm trying to make is that it's a very important neuroprotection tool, not only for all babies, but particularly for the sick babies where it makes a big difference and may add on almost around 8 IQ points. And this is something which I think the world over, there's a lot of interest in, because we know as adults, the big problem is the metabolic syndrome, and breastfed babies definitely grow up and have less problems of diabetes, heart disease, and all. And this is your DOHAD, the developmental origin of health and disease, and how exclusively breastfed babies protects against obesity, protects against metabolic syndrome. And these are benefits which is lifelong. When we look at the mother, of course, it is a lovely feeling to breastfeed the baby. It makes a very good, it stimulates oxytocin, which is the love hormone. It promotes her mental well-being, but it has a lot of physical effects too that we know. It helps in involution of the uterus, reduces PPH. It's a very good family planning method. But do remember, as a family planning method, it has to satisfy 3 criteria. Only then you can rely on it, that it should be less than 3 months. The mother should not have started menstruating, and she should be exclusively breastfeeding. Only then you can rely it on as a contraception method. And for her, there's lower risk of breast and ovarian cancer. There's lower risk of rheumatoid arthritis. A mother who is diabetic, gestational diabetes, the chances of her changing over to over diabetes is far lower if she's breastfeeding. And of course, it makes life easier because it's so easy to breastfeed a baby for the first 2 years rather than preparing formula and all. But We have to talk about these benefits to the mother. And particularly when we are promoting breastfeeding in the labor room, at times we also have to talk to our obstetric colleagues that please do skin to skin contact right at birth. Please initiate breastfeeding the mother, even if she's undergoing an episiotomy suturing, even if she has postpartum bleeding, because all this will help her. For the society, it's more economical, promotes contraception, it makes better citizens. And for us, as health indicators, it reduces hospitalization, infant morbidity, mortality, and overall, you're going to give better citizens, better people to the nation, and therefore it helps in nation building. Now, one important thing which is not there in this presentation, but is very important for postgraduates, and I would like you to read up, is the composition of breast milk. We have not gone into it in this presentation. You should know what is the different amounts of protein, carbohydrate, fat, iron, vitamin A, sodium. These are things which you may be asked in exams, and it's also important when you manage babies. But what we are going to be talking about, the different types of milk. So the first milk, you know, is colostrum. And we know that colostrum is the first immunization. And this colostrum, like everything which is precious, comes in small amounts. So this is a common issue that I see postgraduates talking about, nurse talking about on rounds. They express milk from a mother and say, oh, nothing is coming out in the first 2 days. Colostrum is difficult to express. Colostrum is in small amounts, but even a drop is precious. It's like liquid gold. And why is it so important? Because it has very high amount of antibodies, very high amounts of lactoferrin, immunoglobulins, IgA, and all this helps to coat the sterile gut of the baby and makes it more resistant, not only then, but even much later against infection. So colostrum is very important for its anti-infective properties, first immunization, and it also helps immediately because it's a good purgative. It helps in passing stools, it reduces hyperbilirubinemia, and very importantly, by giving colostrum to the baby, you're establishing lactation in the mother. So please remember, even your 6 small babies should get colostrum. Even your 6 small babies in the NICU, you need to express colostrum from the mother, and then you have to put it into the baby right away. Even if you're shifting a baby to the NICU, please do that. And when you're expressing colostrum, don't go with a big katori or with a big cup. Take a 1 cc syringe and then aspirate whatever comes at the mother's chest when you try to express, because as I said, it's going to come in small amounts. Now, when we look at recommendations, these are something that you should absolutely know and practice. Initiate breastfeeding soon after birth. We used to initially say within half an hour, but now with skin to skin contact at birth. In fact, if you look at, we will talk a little more on BFHI, Baby Friendly Hospital Initiative. Step 4 talks about this, initiate breastfeeding soon after birth. But now what we say is you put the baby skin to skin contact. Don't force the baby immediately to breastfeed, but allow the baby to sort of feel the breast, taste the breast, and then at his or own pace, start breastfeeding. Don't push it. And most babies, almost all of them, would do so within the first 1 hour of birth. So initiating breastfeeding and allowing the baby to lead it is very important. Do not introduce prelacteal feeds at all. And this is something even now we see, even in hospitals, some family member gets very worried that nothing is going to the baby and gives something before you know what has happened. So all this education must be given antenatal, and that's where our obstetric partners come in. Exclusive breastfeeding for the first 6 months of life. It doesn't end there. Continue breastfeeding for 2 years and beyond. Breastfeed both during day and night. And here we talk about responsive feeding, demand feeding, that you let the baby set the goal. And what you do here is allow the baby to decide. And most of the time, baby takes in feeds very, very quickly during the night, very often. And maybe during the day, the baby even may sleep for 3 to 4 hours, sometimes even 5 hours. But in a day, at least 8 feeds must be going into the baby. So while we say responsive and demand feeding, please remember A sick baby will not demand. And that is the difference a mother needs to know. So if her baby is not demanding at 8 times per day, you need to see what is the problem. And allow the baby to completely empty one breast. Most babies, once you're satisfied, they leave the breast and sleep off. If the baby leaves the breast, help the baby to attach again. But if the baby starts crying, then maybe you can move on to the next, the other breast. But it's not mandatory that a baby feeds from both the breast at one sitting. Most babies are satisfied with one breast, and you can start with the next breast the next time. Now, having said that, one important feature here, which we need to educate mothers, we don't want switching. As you all know, a mother who gets good amount of milk and lactogenesis 2 or the secretory phase has started, starts leaking from the other side when she is feeding. So some mothers, when they find the leaking, they think it is getting wasted and they put the baby onto the other side. And some nurses even now say 10 minutes here, 10 minutes there. Now, all this results in problems because you know there are also two phases of milk, fore milk and hind milk. Fore milk is watery. Fore milk has high glucose. Hind milk has high fat. It's important the baby takes the hind milk for weight. And if you give only fore milk, baby may have very frequent stools and baby may not gain weight. So the mother should completely empty the breast and then only go on to the other side and no switching. Shreyasi, if you're with us, if there is any questions in the chat or if there is any hands which are raised to ask questions, please interrupt and let me know. We can take it. Now coming to recommendations for other recommendations for breastfeeding practice. The adequacy of milk intake, how do we know? And this, let me say, is a very common question in your Viva and in your case presentations. How do you know? And this is again a very common question mothers ask, how do I know how much the baby is taking? So the most important thing which the mother should know is urine output. And now with diapers, many of them say, I don't know how many times. So maybe they can keep a count. They can look at not only the times they change diapers, but how heavy it is. And it should be a minimum of 6 times per day. But please remember, this is after the first week. And I hope you'll know the rule of thumb that a baby should pass the first urine in the first day. And then as the days pass in the first week, maybe third day, 3 times, fourth day, 4 times, it increases. And by the end of the week, a baby is passing 6 to 8 times. And that's the minimum number. It's very important to tell the mother that so that the mother recognizes when the baby is not feeding. And what we are talking about weight gain here is for us. We look at how the baby gains weight. Now, we used to think that all babies regain their birth weight by around 10 days, but sometimes they don't. So now you have calculators which look at whether the baby's weight gain and coming back to the birth weight of the baby, is it normal or not? So you can look at it. And after the, the weight gain and all is well established, most babies gain weight around 20 to 30 grams per day. Now, this is very important to monitor because growth faltering brings its own problems. The other ways that a mother knows she has adequate milk is tingling sensations in her breast, in her uterus, when the oxytocin reflex sets in, the fact that the baby sleeps for at least 1 hour after a good feed, dripping of the milk on the other side when she is feeding, all these are signs of adequate milk intake. Now, the other important thing is initiating complementary feed only after 6 months of age. I have got into a habit now of writing on the well baby card the exact date when the baby should start complementary feed, because we know that our concepts of 6 months and all is confusing. Sometimes as soon as a baby finishes 5 months, enters into the 6-month, mothers want to start complementary feeding. So we need to be very clear on it. And let me again reaffirm that even for a preterm, we don't look at corrected age. We initiate complementary feeding at the chronological 6 months of age. I do acknowledge that this is a little controversial area. We still need more evidence. But as of now, as of current evidence, as of current practice, complementary feeding for all babies, irrespective of prematurity, should be started after 6 months of age. And breastfeeding must be continued till 2 years of age, and I want to make a change here, 2 years and beyond. Within pediatricians, there is this thought that in the second year, breastfeeding is not important. Breastfeeding may hinder a baby taking other food. This is something I would totally like to dissuade. Do not, and I repeat, do not make attempts to stop breastfeeding in the second year. I recently remember in one of our academic WhatsApp groups, there was a lot of discussions among pediatricians of how to stop breastfeeding because either baby was not gaining weight or the mother wanted to go somewhere, but please do not stop it. Even in the second year, breastfeeding, breast milk contributes to a third of the calories which is needed and half of the proteins. It's a very important source of nutrition. Now, why is the term beyond there in all guidelines? That is because a baby may want to continue breastfeeding, and if the mother is fine with it, it's perfectly okay to continue it as long as they want. It could be 3 years, it could be 4 years. I have mothers who have even given it till around 5 years of age. That's up to them. There's nothing wrong with it. Now, so these are the recommendations for breastfeeding. A little bit on the anatomy. We know that the breast has glandular tissue and it's a supporting tissue. So the size of the breast is dependent mainly on the supporting tissue. So even there is a small breast, it doesn't really matter. She will be able to breastfeed well. And here you have a picture of the anatomy of the breast. And here you see here that very importantly, you have your alveoli and you have this myoepithelial cells which contract only when the oxytocin kicks in. So therefore, if you do still have milk, I don't know whether you see my pointer, unless the oxytocin reflex sets in, the milk is not going to flow. And what is going to govern the oxytocin reflex? We'll come to that. It's stress. If a mother is stressed, oxytocin doesn't set in, then even with good milk, the output will be less than 4%. So it is very important to make oxytocin your friend. And then you see here that all of it comes into the areola. We used to think earlier that they were lactiferous sinuses and dilated, but now we know that it's not true. There are no sinuses as such. It's just the ducts which are going into the areola. But this is a good position here for expressing breast milk. That's what you need to know. And supporting tissue amount, the fat doesn't really make a difference. Now, most nipples are nicely protruding like this, but sometimes they are inverted or flat. Flat nipples, we have no problem. Now, as far as physiology is concerned, there are 3 reflexes: sucking, rooting, and swallowing. And why it is important for us to know this is, for a baby to breastfeed, all these 3 reflexes should work well. And this is where the gestational age comes in, that till the baby is around 34 weeks, the coordination between these reflexes, particularly with breathing, is not there. And therefore, we need to give supervised feeding. And we have gestational age, like less than 32 weeks, most of them may need gavage or tube feeding. 32 to 34 weeks, they may need Paladay, but you can start breastfeeding. And actually, between after 34 weeks, you can make them directly breastfeed, but it may need to be supervised. And the very mature suck, breathe, swallow coordination happens in the term baby. When we look at physiology, please remember the prolactin reflex, that is the milk producing hormone. It helps prepare milk for the next feed. It is produced from the anterior pituitary. And this is where we congratulate mothers whose babies are disturbing them at night. It's a common complaint. My baby doesn't sleep at night. My baby is crying. I usually say, very good. I would like to congratulate your baby. The only thing that you need to change is try to get your sleep when the baby sleeps during the day, because prolactin is more at night. And therefore, we need to ensure that the baby has unlimited access to feeding. And that is where we believe that baby should be sleeping with the mother. As a tradition, we promote co-bedding. So the evidence from the West is very iffy, but we do promote co-bedding to promote feeding, especially at night. Now, when we look at the other one, this is the notorious, very moody reflex, oxytocin. If a mother is worried, stressed, pain, doubt, confidence is low, then oxytocin doesn't work. And that is where counseling is important. I realized very late in life that counseling for breastfeeding is not about transferring knowledge. There is only one single goal when we counsel mothers for breastfeeding, and that is improving her confidence. If we do that, everything will set in naturally. So, whenever there's any problem with breastfeeding, first goal you have in counseling is to make the mother feel good, to get the family to make the mother feel good, calm, relaxed, stress free. And whatever is going to help with that, whether it is back massage, breast massage, talking to her, birth companion, all this is needed to make the oxytocin your friend. Then we come to something which we are very good in helping, which we all know. And as a postgraduate, this is a must know for you. And these are taken from the IMNCI modules. I know there are various other things which are added, but please learn these 4 points about correct position. The baby is well supported throughout. Head, neck, and body are in the same plane. It's straight, and not that the baby is turned its neck and feeding. You can't feed like this. And the mother supports the entire baby. The baby totally faces the mother, and baby's tummy and the mother's tummy touch each other. The 4 important points of correct position and the 4 important points of correct attachment. Here, what you can see is always this, the chin touching the mother's breast and majority of the areola inside the baby's mouth. This one, lower lip turned outwards, may not be seen very well, and there's no need to see it if the others are good. And this one is important, baby's mouth wide open, because the point at which the baby does open the mouth wide, that is the time you have to quickly help the baby latch on. And I think most of you postgraduates are familiar with the scoring latch, which is an acronym which helps in identify problems with attachment. So when we look at problems during breastfeeding, in fact, I think of my postnatal ward rounds of normal well babies as breastfeeding rounds, because most of the time, this is what we are doing, supporting mothers with breastfeeding. And this is linked to the other problems which we find commonly in the postnatal ward, that is jaundice. So what are the problems? One of them is this inverted nipple. Many postgraduates think that a flat nipple is inverted. The difference is when you hold at the junction of the areola and push it back, if the nipple goes in rather than coming out, that's an inverted nipple. You should identify it in the antenatal period. And then towards the end of pregnancy, definitely in the 3rd trimester, you could start rolling it out to help it come out. Now, many obstetricians are concerned that they may trigger labor, and that's why we said you do it after the gestation passes into the term category and not in a preterm baby. The other problems we commonly face is sore nipples. And sore nipples you find more commonly in mothers who are sticklers for hygiene, who keep rubbing their breast before every feed. And the most important reason is incorrect attachment. So always ask this question, how is breastfeeding? How comfortable are you with feeding? Do you have any pain in your breast? Because these are important conversations to have. If a mother has sore nipples, you please look at it. You look at attachment, talk about whether... Okay, I would like you all to mute the participants. I would request Shreyasi please mute participants if there is any disturbance. Otherwise, you could also make me a co-host and I could do it when there is a disturbance. Okay, so sore nipples is something you take care of. The other problems that we have in breastfeeding, which are much worse, is of course breast abscess, breast engorgement. Please differentiate breast engorgement from breast fullness. If it becomes hard and tender, that's a concern. If it now has tenderness along with increased temperature, that's mastitis, and that can lead on to a breast abscess, which really hinders breastfeeding. So please, the solution to all this or prevention of all this is good expression and complete emptying of the breast. The other big problem, which we see all the time, and I think almost all mothers feel sometime in their life that they have reduced milk, not enough milk. And the main reason is her confidence, making sure that the baby has unlimited access, the baby can feed often. Feeding is the one which helps this. Make sure she's relaxed, and then she feeds the baby often, and this is going to help it. Here you see the syringe technique to treat inverted nipples. One word of caution, please use an appropriate size. At least 10 or 20 ml, 20 cc syringe is needed. Yes, there is some controversy now whether you still need to do it. But important thing that I would like to highlight is whenever you do it, it should not hurt the mother. And definitely do not use it as a form of expressing milk, which I see some of them do it. Now coming to breastfeeding in the preterm baby. We talked about this suck, swallow, breathing reflex. But what you need to understand is that breast milk is the best milk for the preterm baby. It is unique. It meets the unique demands of the preterm baby, that like increased need of proteins. It has double the proteins that a term milk has. It has higher vitamin A, higher sodium, higher immunoglobulins, and therefore preterm milk is the breast milk for that baby. So even if you have donor human milk, please promote mom. And what is mom? Mother's own milk for her preterm baby. And here it is said that mother should begin milk expression within 6 hours. I believe that a preterm mother is no different from any term mother. She should start milk expression within the first hour. Repeat it at least 8 to 10 times per day. Very often, even now in my own unit, I hear mothers on day 3 who may have had, who was sick, who couldn't come to see her baby, whose baby was sick. I ask her, did you express milk? She says, nobody told me to express milk. And my baby is not drinking it. So please dispel these, actively talk to them about expressing milk. And even if the mother is separated, she should come, touch and see her baby. Even if the baby is not drinking milk, she should express her milk every 2 to 3 hours. And this express milk can be stored at room temperature for 6 to 8 hours and in the refrigerator for 24 hours. And if you have a freezer compartment, you can even store it for 3 to 6 months. Therefore, we all should be familiar with the 10 steps of successful breastfeeding. These pictures here, which are from WHO and UNICEF, highlight the 10 steps of BFHI. And this is something that all hospitals should follow, that you should have a policy for it. Your staff should be all trained. And when I say trained, it's not just one day workshop. Ideally, they should have at least 18 to 20 hours of training. All mothers should be antenatally educated. Step 4 is early initiation in, can you see the picture here, skin to skin contact. Support the mothers for breastfeeding. Ensure that she does responsive feeding. Feed more during day and night, and definitely do not use any bottles, teats, or pacifiers, and give them support even after discharge, like a support group. All these constitute the 10 steps of successful breastfeeding. And the first step is further divided into sub-steps where you talk about having a written feeding policy and also establish a monitoring system to see how it is going on well. The others, as we discussed, we have the 10 steps, which I'm sure all of you all are familiar with. And it's again something that a pediatric postgraduate must know. Now, the last topic that I'm going to take, and that hopefully leaves me around 10 minutes of interaction with you all, is about what the government of India has done to promote breastfeeding in the past decade. Here, we believe that initially we thought breastfeeding is natural, doesn't really need much support, but now we know that all mothers need support, whether the baby is high risk or no. And therefore, this kind of support needs to be given at all levels of care. So we have the NHM policy, which talks about Comprehensive Lactation Management Center at a district hospital level. At a sub-district level, you have the lactation management unit and a lactation support unit at even the primary healthcare level. What are the functions of these? If you see here, this is what I said. Phase 1 is in medical colleges and district hospitals. The lactation management units is in a sub-district hospital, maybe with a functional SNCU, but the lactation support unit should be at all delivery points. So when we say a comprehensive lactation management center, ideally, you should even have a milk bank or donor human milk, and you should have facilities for expression and storage. In a lactation management unit, you have all this, but may not be a milk bank, but at least you should be able to store unit and give it to their own baby, store milk and give it to their own baby. But at all delivery points, you need the people to be trained to provide lactation support. And the most important aspect of all this, as I said, as a pediatrician, what we should know is counseling. And this counseling, even if you do not attend any workshops, I would invite you to look at the document on infant and IYCF documents, which talks about how to counsel, how to be, the body language, the non-verbal communication, what is the difference between empathy, sympathy, closed questions, open questions, not being judgmental. These are the extremely important aspects of breastfeeding counseling that all of us as pediatricians should know. And let me tell you, counseling is going to take time. You can't do counseling in a busy practice. So if you become a pediatrician who do not have time, at least identify good counselors who can provide the right advice. Why am I talking about this? Because I strongly feel that we as pediatricians are one of the biggest culprits for uh, high non-exclusive breastfeeding rates in the country. Because it's so easy to write a formula rather than spend half an hour to 1 hour in doing good counseling. On that note, I would like to stop and I would like to take questions. And it would be good if I can, let me first see the chat if there are any questions. And I'm very impressed that we have 140 participants now for a topic like breastfeeding, which I know is very often not really it's not connected. Okay. So the chat should be open and let me see if I can see the chat questions. Okay, I don't see any chat questions, but I would invite the participants to raise their hands and ask any questions. Otherwise, we could have a discussion and I will maybe call out randomly some topics which you may have to answer on. Any questions? Anybody would like to clarify something? Ask anything that you have found on rounds has been challenging? Mm-hmm. 139 participants and not a single question. Okay. So then at least let me find out from you all. I know there are a lot of participants from Andhra. Initially, I saw at least a couple of them. Can any of you all talk about the challenges that you're faced when you are doing rounds in the postnatal wards and what specific measures you have taken to, is it that you can't talk? I think only some of you all can. I see the talking icon only against some of you all and not all of you all. So please use the chat. Okay, since a very general question like that did not elicit any questions, how would you all like to manage twins? How do you like to manage breastfeeding and breastfeeding position in twin pregnancies, in twin babies? So may I ask Akash? Akash, you are the first one to respond. And don't worry, even if you don't know the answers, these are just ways and means for me to take it forward and make it interactive. Yeah, go ahead. I heard someone who wanted to say something. So any thoughts, if you're feeling shy, you can even put it in the group. What are the breastfeeding positions that you would like to advise to twin babies and why? You could put it in the chat if you wish. Okay, I see that. Oh, there are some questions here. We'll take it. Okay, football position. Okay, someone has sent me direct messages. Okay, let me take up these chat now. Okay, so let's have. I'm just looking through your chat, so I can't see my screen very well. So the first thing for twin pregnancies is always high risk. The one is because there are more babies, and therefore you need to support. But at the same time, please rest assured that it's absolutely easy to ensure exclusive breastfeeding for twins, even maybe triplets and quadruplets, it becomes a little difficult, but it's possible. Twins, definitely. So what are the positions you would like? First thing, remember, try to promote both the babies to feed at the same time. It has four main advantages. And the first advantage is that it saves time for the mother. The second advantage is that because both of them are suckling well together, it has doubled the prolactin and all, and therefore milk production is going to be more. The third thing which is going to help is this, you have your baby bonding between the two babies that it is going to promote. And the last thing, which may be useful, particularly in discordant twins, one of the twins may be small, may not be able to suckle. When the bigger twin does it, he automatically or she automatically gets the drip milk. So without much of an effort, the smaller baby also is supported. So these are the four advantages. And like one of you all rightly pointed out, yes, football position like this is very good for twins. You could also do the modified cradle, but of course not a full cradle, but you can just hold the babies and feed. Why is football position very good? Because many of the twins are also preterm. And for preterm babies, football position is good because you're supporting the baby fully. And at the same time, especially babies who do not have good tone, this is a good position. And even you could use a dancer hold for such babies if they have hypotonia. So there are different positions, and the position I like best is the cross cradle position. I find that very, very useful for new mothers who struggle with breastfeeding, because then we are giving them a tool to support on their own. And what is cross cradle? Here, you're supporting the baby with one hand, totally supporting the baby. I don't know whether you can see me. And with the other hand, she holds her breast and feeds the baby. But do not promote only this. Show her the different position, including side lying for C-section mothers, straight position, so that you can help her. So let me go through the questions which are there. Ma'am, can we initiate express breast milk via NG tube when baby is having soft tachypnea or mild respiratory distress? Absolutely. In fact, most of our babies who are on CPAP or even on ventilation, if they don't have any other problems, we are giving express breast milk through the NG tube for the baby. So it is definitely needed. Some of the babies on CPAP are even made to feed directly. The second question is, postpartum women complain a lot during the first 3 days about less supply and insist a lot on prescribing formula. Now, this is where we need to give the physiology behind it. It is important that we as nurses and doctors give good counseling. As I said, our body language, non-verbal communication is very important. I see a lot of nurses who express and say, oh, nothing is coming. And therefore, you need to build her confidence. And if it is a small baby, if it's a sick baby, you're worried about hypoglycemia, you need to monitor such babies. And milk takes time. It comes in a little later in primaries. And also, if they have had C-section, we have found there are issues So just build her confidence and ask her to wait. It is going to come in. What is important? And therefore, I always clarify when I ask a question. I don't say, how is the baby? I don't ask, how are you feeding? I always ask, is the baby suckling well at the breast? It's the baby's job. So please transfer the responsibility from the mother to the baby. Let her feel comfortable that as long as the baby is sucking, that's all that the baby needs to do. Okay, Priya wanted me to explain about different breastfeed positions. Um, Please also Google it because I know that you can't probably see me well. But the important things, what we always talk about is the modified cradle, where you hold the baby well supported in the nook of the arm and support the whole baby. You hold the breast with the other hand and feel. Then you have the cross cradle, where it is supported with, the head of the baby is supported with one hand and she supports the breast, side lie, straight position. Straight positions is good for especially if a baby has a cleft palate or so. The vertical position is very good. Football position, as we said. And the dancer hold is just about how the attachment is supported, where the mother supports her breast and the chin of the baby. Okay, so some of the things, ma'am, what advice can be given for post-LSCS mothers who complain no milk or less milk ejection? Make her feel comfortable, build her confidence. It is all going to come in. And the peer support is very important. If you have a ward where one mother is doing well, take her, and your nurses need to do a good job of counseling her. They have to wait patiently. And please talk about colostrum, how it's even a small amount is very, very enriching. Okay, someone said, can you please talk a few points about NNS and when can we initiate in NICU admitted babies? NNS, for your information, is non-nutritive sucking. Every baby should be on non-nutritive sucking. What do you mean by non-nutritive sucking? The baby is made to suckle at the breast, not for getting milk, not for nutrition, but just for practice. And so how do you do it? In the West, they use a pacifier. We are strongly against pacifiers because it can be a source of infection. We ask to do it on the mother's breast. But if you have a baby who can't be moved much and all, you can also use the mother's finger to give non-nutritive sucking, washed finger without sanitizer, but washed and dry. She can give and stimulate the palate to do non-nutritive sucking. But we definitely encourage babies who can, including CPAP babies, to do non-nutritive sucking on the empty breast. And when can you start it? You can start it from day one. You should start it from day one. And here I bring my experience from the immediate KMC study. And in this immediate KMC study, all babies who are very, very small, even if they were sick on CPAP, were made to just be with the mother in KMC position. And this encouraged a lot of sucking, tasting, licking, and even they were made to do non-nutritive sucking. So there's no limit to when you can start. So I think those are the questions that I see here. And I'm happy with your question. Okay, there are some more. How fevers affect breastfeeding? Okay. So the fever, the mother who is having fever, you can still encourage her to breastfeed as long as she's not very, very sick. And why we say it's okay is if it's a viral fever, both the mother and the baby are exposed to it. By breastfeeding, she passes antibodies to the baby. So that is fine. And second, now, if a baby falls sick, the mother's milk will help her. And very often, the breast milk is not going to transfer this viral thing, and she can still wear a mask or so if she has a respiratory infection. That is about mother's fever. Now, there is another entity, and I don't know whether Adil was asking this about dehydration fever. By around 2-3 days, sometimes a baby may have higher temperature, and this may be an indication that the baby is not feeding well, and they will have to make special efforts to improve it. Okay, so I think all the questions have been answered, and we are on the dot. I promised you that we will finish at 9 o'clock, and we have done. I had a good time talking to you all. I also found that maybe if I had a breast model, and this is for Pratima and others who will be taking this forward again, a few accessories for us to demonstrate like a breast model. And maybe I think we need to also show you a few pictures on the different positions. I think in our next courses, we'll do it. Does dengue virus transfer to breast milk? No, we still encourage mothers who have infections to transfer. HIV does get transmitted, but we all know now that for an HIV mother, there is no change in breastfeeding. It's the same, but we need to ensure that she is on medication. So I think on that note, I would like to close, and I thank the 130, 140 participants who are part of it, Shreyasi, Pratima, and Dr. Tapas for their support. Thank you and good night. Shreyasi, I will be logging off. Is that fine? Mhm.
లాస్ట్ టైం అయితే